today, so feel free to ask questions along the way. I'm happy to answer them to the best of my ability. And feel free to also email me or look me up on Twitter if you have future questions. So I want to acknowledge that some of this work is funded through a GEMSTAR R03 grant. That's a Transition to Aging grant through the National Institute on Aging, and also by a Paul B. Beeson Award. I also received support from Apple. They provide the Apple Watches for my K Award, but I have complete independence in terms of the scientific content of this work and publishing. I also want to thank my collaborators who are listed here. So I'm going to start with the bottom line, which is underreporting of falls causes missed opportunities for fall prevention. We know that only about 1/4 of older adults actually tell their primary care doctor that they've had a fall. And it's very hard to prevent falls when you don't know that the person has fallen. So that was the impetus for us getting involved with this research, developing techniques for objective fall outcome measurement. And here what you can see is a notification that is provided on an Apple Watch that there is a session that a patient in our clinical trial needs to do. And on the bottom, you can see some of Apple Healthkit measures. So heart rate, number of times fallen, resting heart rate. Our patients actually opt in to have their data provided from their devices directly into our REDCap. And so that's what I'm going to talk about today, because it's not intuitive how to set up how this data gets from the watch into a HIPAA compliant software program. And I'm hoping that we all take something away from it. So I'll start with a case study of why we did this work. I'll talk a little bit about our fall prevention studies. Second, I'll talk about how to design a technology pilot. So how did we start this work? I'll also talk about Apple's Researchkit and Apple Watch in case you're considering that for some of your studies. And then finally, what are some of the results and what have been the opportunities and challenges of this research with wearables? And because I do research in aging and in older adults, I'm going to be talking specifically about that population, but I believe this is very applicable to other populations that might have lower digital literacy. So what do we know about falls among ED patients? So interventions to address increasing fall-related ED visits and improve care transitions for patients from the ED to home is a major research priority in emergency medicine. And that's because falls cause 3 million annual ED visits. In fact, 90% of patients that are over the age of 65 that come to the emergency department for an injury are there for a fall. So it's a major problem, and yet it has very little public health funding to go with it. And there's very few interventions that start in the emergency department for fall prevention. And we also know that falls are a sentinel event. So it's really a symptom that there's something going wrong with that older person. There's lots of risk factors for falls, including vision impairment, weakness, gait problems, balance problems. And we know that once patients leave the emergency department, it's often not the last time we see them. So if you've left the emergency department due to a fall, about 43% of those patients revisit the emergency department within 6 months. And we also know that disability increases caregiver burden. So this is a really important topic in emergency medicine and in geriatric emergency medicine specifically. So as part of a pilot R03, we designed a randomized control trial of 110 patients where half of them received a CDC brochure on home safety and the other half received a brief tailored in emergency department intervention. As part of this intervention, we had pharmacists meet with patients at the bedside, and they made suggestions for how to reduce fall risk increasing medications. And they used motivational interviewing in that discussion with patients. Then physical therapists come to the bedside and they do a fall risk assessment, and they created a plan to address weakness, gait and balance problems, and other problems associated with falls. And what we found is that we were able to significantly reduce fall-related emergency department visits at 6 months. This is a median cumulative function curve, and it shows you Here, these dots represent ED visits that occurred after the ED index visit at 0.0. And here you can see intervention patients. So you see that the slope is much steeper for patients that received usual care. That means that they had many more emergency department visits, especially in the near term after their ED discharge. So we were excited about these results, but and also excited that we showed feasibility. So we didn't increase length of stay in the intervention arm. The intervention was highly acceptable to patients, caregivers, and clinicians. And we were excited that we reduced recurrent ED visits for falls. But we also had problems in our trial, which brought on deciding to use the Apple Watch in our follow-on study. Traditionally, when folks have done falls prevention research, they've used fall diaries, and patients every day would sit down with a fall calendar or a fall diary and write down if they had a fall or not. And then on a monthly basis, they would send that in. We attempted to do this in our GAPcare pilot, but found that among our highly vulnerable ED patients, fall diaries were often incomplete or lost. Finally, memory impairment impacts fall recall. So we had about 20% of our patient population had cognitive impairment, and we found that they had a difficult time recalling falls, even when we saw that they had a fall in the electronic health record. And the other issue that we had in our study was that control patients, so patients that weren't seen by physical therapy, received less assessment of function. So we had a difficult time. We couldn't really analyze a lot of their functional measures. So that's how we came to the idea to use wearables in our follow-on study. So clinical trials on falls previously relied on self-report, caregiver observed, or clinician reported, or EHR abstracted fall outcomes. That is a problem, because ideally you would like objective measures, such as what can be measured by the Apple Watch. And as I said before, only about 28% of fall-related injuries are recalled compared to Medicare claims. So we made the argument that we needed objective outcome verification with sensor-based devices. So falls researchers have used sensor-based devices in prior studies, and those had some limitations, which I'll discuss. So there was a study of waist belt sensors in 160 community dwelling adults, but they only used the device for 1 week. So one of the issues with wearables is how long can that population wear the device, how often do they need to charge it, and how feasible is it to do longitudinal measures if a patient's only going to wear it for a short period of time. There was a study of 384 inpatients using wearable sensors for gait and balance, and 82% reported acceptance. So in the last 10 years, there's been a astronomical increase in wearable sensor use. And generally, they do have high acceptance. And so that is a facilitator of this research. Previous fall detection device studies didn't involve older adults, caregivers, and patients with dementia. So this is a big gap in this research. And often these studies are only done in healthy and technology savvy adults. And so it wasn't clear prior to us embarking on this how easy it would be for our older adults in our trial. We had a median age of 82, how savvy they would be in using this technology. So that impacts how you design your studies. And there was a 2018 review of wearables for fall detection, and none of the 9 studies evaluated the accuracy of the technology on older adults at home. So a lot of the falls prevention research involves patients being on a treadmill and falling on this treadmill, so having a simulated fall, and that's how they use the sensor-based technology. But obviously we want to know if falls are actually accurately detected when patients are falling at home, not in a lab. So I'm going to share the design of our aim-1 of my career development award. And what we decided to do in order to fill some of these gaps is determine how our population, specifically ED patients that come to the emergency department for a fall, how feasible, acceptable, and usable the Apple Watch technology was for these patients. And we determined that we would do 25 interviews with ED patients. And then for the 5 patients that we aim to recruit with dementia or some cognitive impairment, we also wanted to interview their caregivers. We designed the study so that initially research staff would use the electronic health record to screen participants. And our inclusion criteria was patients that were 65 years or older, or they were a caregiver of a patient with dementia. They had to be in the emergency department due to a fall, and they had to be likely to be discharged. And the reason we chose these inclusion criteria are the inclusion criteria for our clinical trial that is following this study. Finally, we consented the patient and used proxy consent for patients with dementia. While the patient was in the emergency department, we trained them in how to use the Apple Watch. And as we'll discuss soon, some of these patients have never used a phone before. Some of these patients have never used an iPad. And so training was really essential for this population, because prior research on wearables and technology in older adults shows that with training, they can learn how to do these studies. However, the training is really essential. And we not only had to train the patients in using the Apple Watch, but also how to use the iPhone, because with the Apple devices, you have to have an iPhone linked to every single Apple Watch. And we also had a research app on the iPhone and the Apple Watch that patients had to learn how to use. So they received training on all of those things while they were in the emergency department for a fall. Finally, we asked patients to do some field testing for us. So we asked them to wear the watch, charge it every day, and answer surveys once a week. And then at the end of the 30 days, we offered them a qualitative interview and asked them questions surrounding feasibility, acceptability, and usability of the Apple Watch. So let me back up a little bit. How did we actually design the technology to make this possible? So the first thing we did was program surveys. So we used REDCap, and we programmed demographic and fall surveys into REDCap. And some of these were research staff administered. So they would ask patients when they met them in the emergency department, what was the reason for their fall, when did their fall occur, and basic demographics. And then some of the surveys we designed in REDCap were designed so that patients could answer those surveys. For instance, we had a daily fall calendar survey. So patients would be asked on the app every day, have you had a fall today or within the last 24 hours? And if they did have a fall, we asked them questions on whether they went to the emergency department or had any healthcare utilization related to that fall. The second step in designing the study was selecting Healthkit measures. So Apple has pre-programmed Healthkit measures that are relevant to falls. And I'll give you an example. For instance, heart rate. You might want to track heart rate of patients immediately prior to them falling. Some patients develop bradycardia, and that's the actual reason for their fall. And so what we did is we entered code from that Healthkit measure into REDCap, which told REDCap via API, which is this electronic method of communicating between REDCap and our research app to extract that data from the watch. Third was active tasks. So we had to determine which Apple Researchkit Apple tasks to include in the app. So I'll give you an example. They have a trail making test, which tests cognition. And we chose that trail making test as one of the active tasks that we wanted patients to do when they were at home on this iPhone device that we provided them. The fourth step was to enable API. The API is an application programming interface, and it allows immediate transfer of data from your research app into REDCap. So this is really important in fall studies because you would want to know immediately after that patient had a fall that it occurred, because then you can call the participant, you can ask if they are okay, if they're planning on going to the emergency department, why they fell. And so it's really important with these wearables that you have API enabled. And this was actually something that required a lot of regulatory work, because not all institutions have API enabled within their REDCap. And so I was the first person at my institution to ever suggest doing a study like this. And so one thing to be aware of when you do this digital health work is to be cognizant of the infrastructure at your university, and you may need to do some education about the benefit and the security and the safety of these kind of technologies. Now it's becoming much more standard to have API enabled, but it's still not universal, and there are restrictions sometimes on whether you can export or import. So that's a necessary step prior to initiating this work. Finally, we did pilot testing. So we tested the app usability among a small group of people in the research team. So we had them do all of the measures that we had selected and made sure that if the research staff did that measure, it actually ended up in REDCap. And so that is really important feedback that you need to give to the developer when you do this work. And finally, then we were able to start our field testing among patients and begin recruitment in the emergency department. So what kind of instruments did we choose? Together with a neuropsychologist, we chose several measures for cognition. So we chose the trail making test, Stroop, and reaction time. We felt that all of these would be important and relevant to falls. And these are the active tasks that Apple has already pre-programmed. I'm going to show you a screenshot of those later, but essentially one of the benefits of using this technology is Apple's created a way that patients not only get verbal instructions on the screen of how to do this measure, but they also, it also reads it out to them out loud. So for people that might have vision or hearing impairment, that can be very helpful. And there's also tactile stimuli. So for instance, for our gait and balance tests, patients have to walk and then turn around, and you get a tactile stimulus on your watch when you have to turn around. So you get multiple prompts, which is useful for this population of older adults that might have disabilities. We also wanted to test patients' mobility, ideally from home. So we selected the gait and balance and the timed walk test. And then in terms of the Healthkit physiological measures we wanted to track fall occurrences, and also we track heart rate, and there's several other measures that, that you can select, but those are the ones that we thought might be relevant to us. Finally, we also created surveys and had interviews to assess feasibility, acceptability, and usability. So overall, what we planned to do was spend a year doing this field testing phase where we would collect qualitative data after patients did use the watch for 30 days. We would then do our qualitative data analysis. Finally, we would allow this qualitative data to inform whether we should have participants wear the watch every single day in our clinical trial, and we built this as an alternative into our initial grant application, or should we do periodic measures using the Apple Watch? So ideally, we would want patients to wear the watch every single day, only take it off to charge it for the whole 1-year follow-up in our clinical trial. But we also recognize that we had never used this technology with older adults before, and it was possible that we couldn't get daily measures. And so we built a alternative into our application saying that if patients aren't able to wear it every day as determined by AIM-1, then we would do periodic measurements by having our research staff go to the home of participants, put the watch on patients, and actually lead them through those measures. And as you'll see, we actually needed to default to the periodic measurements because for many reasons, it was challenging for our patient population to wear the watch every single day. And currently we are in this clinical trial phase where we're recruiting patients in the emergency department and tracking and collecting Apple Watch measures in those patients. So these are our exact aims, which were to, in year 1, to conduct field testing, to then conduct a small open trial in preparation for our pilot RCT to allow our PTs and pharmacists to practice doing the GAPcare intervention, and then finally to do a pilot RCT of 200 patients. So a little bit about what we did in the emergency department with these patients. So we know that some of these patients probably have never used a watch before, or at least not a digital watch or wearable, and that they may not know how to use an iPhone. So we took the patients through a series of different stages to see how competent they could get in using this technology. So the first stage was we asked them in the emergency department after we demonstrated it to apply the Apple Watch to the wrist, to turn it on and to charge it. And then they showed us whether they could do that, and we would track that in REDCap every single step. Finally, we asked them to access the Research app and to follow directions to do the gait speed test. So this is a test where they had to walk 30 feet and we measured how fast they could walk. Finally, if they were able to complete those first two steps, they were asked to take the device home and use it. And on day 3, our staff called and asked them, are you using it? And we also tracked in REDCap whether they were applying it every day and for how many hours they were applying it. Then they had to perform all the tasks required for the randomized control trial. So there were 5 different active tasks we asked them to do at home. And we did that under direct supervision. So we actually went to patients' homes and watched them do all of the active tasks. Finally, they were asked to perform all the tasks at home with telephone support and then perform all the tasks for 30 days as part of our field test. So why would you want to use Apple Researchkit in your research? There's already pre-programmed modules. So you theoretically do not need a developer to do this work, although it's very useful to have someone with the experience that a developer has. Participants can perform tests at home using their own devices. So we started this study in 2019 before COVID happened, but now I think we all understand how valuable it is to not have participants come into the hospital or come into research offices and to use devices at home. And finally, for us, which was very important, is that sensor-based research allows for objective measures of fitness, cardiovascular health, and sleep, because in our prior pilot, we use self-reported measures and the electronic health record, which has limitations. Here's an example of what you can find if you go to researchkit.org. There are many different active tasks, and you can select which active task makes sense for your study. It's categorized by the type of sensor that's being used. So the Apple Watch has an accelerometer that shows how fast you go, a gyroscope that shows rotation. It also has GPS capability. And so depending on what your research study is about, you can choose which type of active task would be reasonable. And there's more than that are listed here, but I think that the website is pretty self-explanatory. Why do we use an Apple Watch instead of another device like a Fitbit? One of the reasons we chose Apple Watch is right before my K Award resubmission, they came out with the fall occurrence detection. And so that was really important for us. Fitbit did not have that ability at the time. Another reason that people sometimes choose the Apple Watch for their research, and I think we're really at the start of this technology being used for research, is that it has FDA clearance of its ECG as a medical device. So you might want to use that home ECG in your research. One thing to note is that Apple does not have FDA clearance for its pulse oximeter. So they're adding new features all the time. And Apple as a company can decide, are we going to go through all the paperwork and the regulatory burden of getting FDA clearance, or are we going to say, this is not for a health purpose, this is a wellness purpose? And so currently they have some of their features classified under this wellness purpose. And so they don't have to present validation data. So that's really important when you're doing your research to understand if they've gotten FDA clearance for that specific feature that you want or not. Another reason we decided to use Apple is because of this open source framework, Researchkit, and we found an investigator who's actually a pathologist who created a status post interface between Apple's Researchkit and REDCap. And that allowed us to program surveys into REDCap and not require a developer for this work. That's important because apps and paying developer time generally costs about $50,000 to $60,000 to build. And so a lot of the Apple Researchkit apps that you'll see that are publicly available, those investigators actually paid $50,000 to $60,000 to have the app developed, but you can do this on a very small dime, such as it's required in a career development award by using status posts, for instance, especially if you're very familiar with making surveys in REDCap. And finally, at the time that we started the study, Apple Watch was really an industry leader in accuracy of its sensors, and their product came off the shelf. So those were some of the reasons why we chose to use Apple Watch for this research. So in terms of our planned analysis, when you're doing sensor-based research, you have to think about what data you have that's episodic and what is continuous, and what type of analytic techniques to use for that. So for this particular study, we have some continuous data from the accelerometer, the gyroscope, heart rate, and GPS. And that requires pre-processing and feature selection and dimension reduction. And then we also have some episodic data. So we collect data from the electronic health record. We have surveys such as the fall calendar, the digital fall calendar. We have these active tasks from the Apple Watch. We have a falls efficacy scale and medication changes. And so you need to think about how you're going to analyze this data based on the shape that it's in. So that is something that you want to build into your studies. So some of the things that we're not doing currently in the clinical trial that you could do with using the Apple Watch and Researchkit is really to classify different phenotypes of fallers based on the results that you get from these fitness and cognitive tests. You could design interventions specifically targeting these phenotypes. You could deliver alerts when early warning signs of falls occur. So even before a fall occurs, if you're picking up frailty or heart rate changes, you could actually potentially alert that patient to sit down or to change their activities based on your knowledge that a fall is about to occur. You could also use these devices to message caregivers to coordinate care. So for instance, Apple's Researchkit allows you to send fall occurrences or to a caregiver or to anyone you select. So we did program that for our participants. And you can also potentially determine fall severity using these devices and inform the need for ED testing. And these are all future directions that have not been described yet in the literature. So some of the key considerations, though, for you before you start this work is, can my population use wearables? There's really a digital divide with some of these technologies, and we had some older people in their 80s and 90s that were very facile with this technology, and then we also had some younger folks that could not use the technology. So determining upfront how if that person is going to be able to participate is important. Finally, cost. So we did receive those Apple Watches for free for the study through the Apple Investigator Support Grant. But you also need an iPhone paired with the Apple Watch. You need a data plan for that iPhone. Many times you'll need to pay a developer, and you need someone who can do sensor-based analyses and work with this type of big data. So that's something to keep in mind. And finally, expertise. So we'll talk a little bit about the team that you need, but it's very useful to have someone with an engineering background on your team, also to have a data manager and folks that are well-versed in this analysis. So from a grantsmanship perspective, really recommend having alternative strategies and listing potential problems, such as, what will you do if your wearable device fails? There are other devices like Fitbit or Verily Study Watch or Vital Patches that can track important health parameters, and you should look into those to see if they might have advantages. For instance, one of the drawbacks of Apple Watch is it has to be charged every day, and I know that Fitbit has a much longer battery life, so that's important if you have people that can't remember to charge devices. Finally, we also included the caveat that if we had data collection difficulties with the Apple Watch and we couldn't use it every day, if our patient population couldn't use it, that we would do periodic assessments at home. So it's really important to not only build in the research staff support for these devices, but also to have that as a contingency plan. So one of the other things we discovered doing this work is that there actually is no Apple Watch or iPhone training manual that Apple puts out. So we created our own manual, and I actually had a medical student, Daniel Strauss, he's the first author on this paper, create an Apple Watch and iPhone training manual based on all of the questions that we received from participants in our study. And so you can see that we talk about the setup and features, which might not be intuitive to many folks. We talk about active tasks and how to do those at home, about the fall survey that participants take. We also heard from many of our participants that they wanted to know about the digital health features of the watch. So for instance, the watch prompts you once an hour to stand up, and they wanted to understand that. And they also wanted to know how they could check their own heart rate with the watch. Finally, we discussed compensation. And then one of the things we built into our research study is that we would pay participants for returning the watch because it is an expensive device. And so one of the things you want to think about with compensation is having a contract with patients that the watch will be returned, and then also compensating them for that. So I believe we provide them with $50 to return the watch, and then frequently asked questions. So this is what this looked like. One thing you should know is that these technologies are always changing. So for instance, the new iPhone no longer has this appearance. So staying up to date is important and time consuming. So I just want to share some of the quotations from our interviews. You can see that we published this data with just 8 of our initial interviews. We had patients of all different ages. The comfort with technology ranged very widely, from one person who said that they'd never used a wearable before and they have zero comfort with the technology, and they were actually fairly young, between 65 and 69. And then we had some folks that were older, but had used a cell phone before and had used wearables before and were much more comfortable with technology. So doing some type of assessment like this prior to starting the study is important. We asked questions about performance expectancy. So you can see that some folks are really agile with these types of devices. They said, I play games, I watch news, I catch up on Facebook, Instagram, what my family is doing. And then we had other participants in our study that said, I'm not a technical person, I'd rather speak to someone on the phone, I'd rather visit somebody. So it's very important that we offer technical support for our patients, and we actually supplied them with a number that was mapped to a Google Voice phone, so that they could ask us questions. And Apple was very clear with us prior to embarking on the study that they would not be offering technical support for research involving their products. And so it's definitely something that's important to build into your budget. Regarding effort expectancy, some folks said, I avoid technology, I can barely navigate a computer, I'm not skilled enough to develop a spreadsheet or anything of that nature, I knew my abilities were limited. And then some people had low effort expectancy, and they just said, I just figured I'd put the Apple Watch on and that would be it. Some facilitated conditions included that many of the participants in our study sought assistance from others, such as family or research staff. So this one says, I consulted my granddaughter, who's fairly tech savvy. She has an Apple Watch. I bought her one when she turned 13. And then we had a person in our study that had cognitive impairment, and they said that they felt that the training initially was not adequate, and they couldn't actually recall a lot of what was said in that training. And so we learned that if we want to work with this population, we're going to have frequent reminders, make sessions shorter, and really make some adaptations for those with cognitive impairment so that they can use these devices. Generally, participants found the watch to be comfortable. They found that since they were learning how to use this right after a fall-related emergency department visit, that was sometimes difficult. For instance, this person said, I thought I would be able to do more. I didn't know what my limitations were going to be after I fell. I was kind of disappointed that I wasn't able to do more. And she said that she actually had she had a radial fracture on the arm that she would have normally put the watch on. And then she had the watch on the other hand, but she was using that hand a lot for things. And so she didn't want to continue wearing the watch. And so she actually dropped out of the study because of the injuries related to the fall. Some participants were divided over their ability to use the watch on their own. And some said by the end, I never did figure it out how to navigate the screens. I would answer some text messages on it if it was one of the options listed as a single word or two. So over those 30 days, there was a learning curve. Some people learned very quickly how to answer text messages, to answer phone calls, to complete the study instruments, and others found that to be very challenging. So just to summarize some of the barriers and benefits of the watch, definitely a barrier is affordability. So at the time, the Apple Watch costed about $200 and users had to own a compatible iPhone. So how we solved that for our study is we had a couple iPhones that we would lend patients that they would use. One of the potential benefits is there is payer support. So some insurance companies, such as Medicare Advantage companies in Florida, they subsidize the cost of the Apple Watch to enhance mobility in their enrollees. So that's a potential source of payment for the future. Another barrier is health literacy, which we've discussed. A potential benefit is data visualization. So users can access trends over time and graphs of the health measures on the watch. So that could be a motivator. Other barriers are digital literacy. Some folks may not be able to use computers and smartphones, but a benefit is this passive tracking. So measuring health data such as heart rate, gait analysis, oxygen saturation, passively without any active involvement is a benefit. And so the fact that the watch could at least do some passive tracking, even if the patients weren't able to use it, as long as they could charge it and apply it to their wrist, was a benefit. And other potential barriers are complete integration with healthcare. So there really isn't a workflow at this time for clinicians to use that data off Apple Watches. As an emergency physician, we sometimes see people come in with their own ECG measurements and say, I think it had an arrhythmia, but it's really difficult to actually get all of the data from that watch or from the iPhone into electronic health record. It's time consuming and there's no exact process for that yet, but there's potential there. And Apple is working on some ways to interface with the health system. And it's really unknown if wearables enhance users' quality of life. So anecdotally, we had some users say, I'm actually a lot more active now because the watch prompts me to get up and move every hour, and I really like the meditation. But other people didn't use that feature, and we don't really know yet if there is a benefit to quality of life. If you're interested in reading more of a narrative of this presentation about how we set up the tech stack prior to embarking on this study, we have a manuscript in Frontiers in Digital Health that you can read. And here are the screenshots that I promised you of the gait and balance test. So it starts out on the screen where it actually describes the activity. It shows you that you should put your iPhone into your pocket so that the sensors can pick up how your gait and balance is. It counts down when the activity starts. It tells you to walk up to 20 steps, and then it buzzes you and says, turn around, go back where you started. And then it tells you to stand still for 20 seconds and it counts down for you. So there is this benefit of the technology telling you exactly how to do these measures. And this is an example of the trail making test, so one of the cognitive tests, where patients are asked to tap on 1 and then A, 2 and then B, 3 and then C, and then it tells you when the activity is complete. This is what this all looks like in REDCap. So these active tasks are recorded as attachments in the instruments, and we can see if the task's been completed in green or if it hasn't been completed in red. And this is exactly where the files will be automatically uploaded via the API, and you can see exactly when the participant started the event and when they completed the event, and if it was entirely completed or not. And if you want to analyze it, you download this zip file. So we have a couple of tables that you can view in our manuscript, talk about sort of the teams that you need, the challenges, what we would do differently in future studies. I've touched upon a lot of these points, but if you are interested in reviewing that information is there. This is a demo of a Stroop report. We did not actually share the results of patients' active tasks with them, but in the future, I think this is where we're going, where you can show the patient where they score compared to their age group. And one of the big things I wanted to emphasize in this talk is that when you're doing the sensor-based research, you really need a team that is different than your usual clinical trial team. So maybe for a typical clinical trial, you need a clinical researcher and a research assistant. You probably would need a data manager as well. But ideally for the sensor-based research, you want someone on your team that is a computer scientist or a biomedical engineer, knows how to create websites, develop software, program instruments, troubleshoot technology problems, validate your digital tests. Ideally, you'd want a data scientist who has knowledge of Python and how to do the best analyses for this type of work. Often you will need a developer to program the research app. And there are multiple different data sets with this research and multiple different subject IDs that get generated. So having a data manager that is experienced with wearable use is also important. So in conclusion, I just want to thank you for your time and really appreciate you having me here.
Thanks, Liz. I appreciate how like hands-on your presentation was. It really almost functioned as a manual of how to conduct this research. Let me start with the questions in the chat, and then if there's time, I'll ask questions I had, but I'll save those for last. So from Holly, we have this question about data and I guess data privacy and ownership. So with respect to Apple, the patient, participant, and researcher, who owns the data from the study? And then do participants get a report or findings based on their personal results?
Yeah, that's really important question. So in our consent forms, and this is where you're going to want to state this, we state that we are collecting this data for research purposes, and that we are going to look at both de-identified and identified data, and that we are going to make it the de-identified data freely accessible after we complete our analyses. So now with NIH requiring data sharing plans, becomes much more important to specify exactly how you're going to de-identify this data, where it will be shared. A lot of folks are sharing this type of data on GitHub. Another important data management issue is thinking about if you're going to be moving this data, how large the data is, and how to do a data transfer, because that I recently moved from Brown University here to the University of Colorado, and there were definitely many hoops to jump through in moving this data due to its large size. So some investigators, what they've done is they've actually had a local team where the data originated, analyze that data, and then not actually move the full data over to a new institution. Patients have not been receiving results of this data. We don't promise them that they're going to get results of this data, but typically after the trial and analyses are done, we will share like manuscripts and those type of results with patients. And they can see the results of some of their tests and some of their physiological measures on the watch and the iPhone. So they have Healthkit access, and so they can visualize that.
Great. And I'll keep going through the chat here, but if you want to unmute, you're welcome to. It's just a regular Zoom meeting. So comment from Hillary about the the great work you're doing here, and is it Hero, about how did you get connected with people who are familiar with wearable devices?
It was fortuitous. So like I said, I was not discussed actually on my first K award, and that was just a traditional fall prevention trial without using any wearable devices. And then Apple Watch came out with this falls occurrence tracking, and I thought that would be like a really great way for not only for me, for my career to expand into this area of digital health, but also to get better objective measures on patients. And so I drafted this grant, and in the process of drafting the grant, I met the pathologist who runs Status Post, who actually has that linkage between Apple's Healthkit and RedCap, and he offered to help me with this work. And so then I knew that it was feasible to do, and so I also would recommend anyone that wants to do this work. There are Apple representatives on every university campus. They generally work in the space where they promote products with educational purposes, for instance, iPads that you can use in your classes, but they also have connections to Apple corporate. And so through through the Apple agent on campus, I was actually connected to the national folks and was able to talk to them about what I was planning to do. And I became one of the first grantees for these Apple Watches for this study. So the Career Development Award is on a small budget, and I was able to kind of negotiate with Apple that we would get these devices to help with that budget.
And then could you say a little bit more about the response to a participant's fall event? What if the participant didn't seek out care? What other, what was your response to that fall event?
Yeah, so we have a data safety and monitoring board for this clinical trial, which means that there's external researchers and biostatisticians that monitor the data. And we specifically put into our human subjects section that if a person fell, that we would call them, that we would ask if they had notified their primary care doctor or caregiver, if they wanted us to call 911 to bring them to the emergency department. And so we definitely had that as a precaution in our IRB, our review, and with our data safety monitoring board. Up until this date, we haven't run into any challenges in terms of people falling and injuring themselves due to the technology, but we also put a caveat in. We also put in our consent forms that it's possible that they could be distracted by the Apple Watch or mobile devices when they're driving or walking, and that could cause falls. And we haven't had an incidence of that, but it's something to be aware of that could potentially happen.
Other questions? Feel free to unmute if you want to ask. I'll ask a question, and just about, your comments about how the technology changes, which is like a gift if it's getting better, and then a challenge if it's in the middle of what you're doing. And I was just thinking even about the piece about my understanding that that now you don't need an iPhone for an Apple Watch, and that's maybe a bigger change because you had to explain the iPhone and the watch. I mean, what are you seeing on the horizon as the next big wave of changes that will either, make this like easier to do, or will help, or maybe get in the way of what you're doing?
So I think we're one of the things that we're getting better at is helping on the actual device in real time, helping patients or users really visualize their data compared to like other people of their similar age. So I think that's kind of becoming more and more possible. I think one of the big barriers to using Apple products is that you do need to have it paired with an iPhone. Apple is now allowing you to have multiple Apple Watches paired to one iPhone. So we don't do this for our study, but you could conceivably only have one iPhone study device and have all of your participants paired onto that. iPhone, which would reduce the cost for your study. It definitely, one of the issues, for instance, that we ran into is we gave our iPhones to patients to pair with their watches so that the data could make it into REDCap, as you needed Wi-Fi or a data plan for the data to get from our research app into REDCap. And some of these iPhones somehow ended up on some spam lists. And so our participants were called by random people, which we obviously didn't want for older participants. So they, so a lot of these challenges that we ran into, we had to sort of troubleshoot at that time, and not very many people at least at my prior university were doing this type of work, nor was there a lot of published research on this work. So I think you have to accept that you are going to be the first one to troubleshoot the issue, and that there might not be a lot of university-like assistance or support at your site. So I think that is a potential downside of doing this work, but it can be overcome.
Yeah, definitely seems like an area you can't anticipate all the things that can go wrong. Oh, sorry to interrupt. Did you?
Oh, no. I just wanted to speak. This is Hiro from Oregon Health and Science University. Such a wonderful presentation, and just amazing to hear about all the hoops, all major hoops that you have to go through and being persistent. And thank you so much for being so generous with kind of sharing all the steps that's involved for investigators like me who are wondering about really wanting to move forward with including objective measures for fall prevention work. One of the question, I have a lot of questions, but one of the questions that I think is important one, and interest of other audience may be the data piece, the data analysis piece, because you gather so much data. How did you kind of make decisions about what to analyze, and the rest of the data that you collect? Could you share a little bit about your thinking around that?
Yeah, so I was very lucky to have a CTR, CTSA program at my prior university that had some analytic expertise in this type of data, and they even before we've gotten to the analysis stage, because we haven't finished recruiting our participants, what I would recommend to people is to download that data, have someone to start working on cleaning it, because it's not intuitive often when you see things in an XYZ axis, what does that mean? And ideally you want that analyst or an engineer to be with you as you're designing the study, because they need to see okay, you're going to consistently apply the wrist on apply the watch on this particular wrist, or you're going to put it in this fanny pack, so it's going to be lying in these coordinates, and this is how you have to direct the patient to walk, and how you have to direct them to return. So I think there's still going to be some hoops we jump through as we're continuing to complete the analysis, but my best advice would be to have someone with you as you're even designing the protocol, to make sure that you consistently approach applying the device and using the device the same in every participant. And be aware that you're going to be sending them home, so they're going to be doing something totally different at home with these devices. And so, yes, really great question. I'm sure there's going to be a lot of lessons learned that I'll be sharing in the future about that too.
Great, thank you so much.
And with that, we're at time. So thank you again, Dr. Goldberg. Thank you all for attending. Like I said, there will be a recording that's available via our website within the next few days. And please join us in February for our next webinar. Thank you so much.
Thank you everyone for attending.